This brief presentation is an assignment for Nursing Informatics at East Carolina University that will discuss improving health information exchange interoperability in North Carolina. To begin, I would like to start with some basic definitions to improve content fluency and concept understanding during this presentation. HIE, or Health Information Exchange, involves the transfer and sharing of electronic medical information or data between parties. Some examples of how this is conducted is through directed exchanges from a provider to a patient, as a query-based exchange to gather additional historical and helpful information about a patient when delivering care, and as a customer-mediated exchange which would allow a patient to access and utilize their own electronic health information. Interoperability describes the ability of multiple information systems to share and utilize generated data. Thus, HIE interoperability is specific to the effective sharing and utilization of health information within a network. So why is it so important that effective interoperability of HIE take place? The short answer to this question is that the utilization of the data collected and shared allows for the culmination and synthesis of available information. When analyzed with respect to problems, this information enriches available knowledge that is used for solutions to problems, to study solutions to problems, and as the foundation for optimal decision making. Most importantly, when interoperability of information is successful, valuable improvements in patient care can be made and measured. These include reducing readmission rates, monitoring public health, improving diagnosis and accuracy, eliminating medication errors, managing cost, and putting an end to duplicate testing. In fact, by improving HIE interoperability, efforts made by healthcare providers to improve the quality, accuracy, and value of the care that their patients receive is optimized, in addition to identifying, studying, and addressing key health issues included in statewide and national health initiatives. There is a caveat, though. Ethically, the valuable data points within the information network belongs to and represents individual patients. As a result, the non-consensual sharing of health information can result in ethical challenges that can potentially result in malfeasance. Because HIE consists of confidential patient medical information, there are rules and laws that govern how this information can be exchanged and utilized, that maintains moral, ethical standards, and patient privacy. HIPAA and HITECH are two of the most important federal laws targeting the protection of patients' rights within the current climate of advanced technology. HIPAA, or the Health Insurance Portability and Accountability Act, became a law in 1996 and was designed to protect patients and their health information, ensure insurance portability, and prevent fraud. Within HIPAA, the 2003 privacy rule is important as it designates ownership of health information to that of the patient, details the rights of the patient surrounding this information, and strictly dictates what permissions are required to share this information electronically with additional parties. The Security Rule of 2005 added physical, technical, and administrative safeguards within HIPAA that further strengthen protections to PHI by way of impacting policies and procedures. As components of HIPAA, the Security Rule and the Privacy Rule work together to provide protection to patient health information with the advancement of technology in mind. The HITECH Act, or the Health Information Technology for Economic and Clinical Health Act, was developed and initiated in 2009 and introduced the concept of meaningful use of electronic health record information and also addressed information technology related to Medicare and Medicaid. HITECH aims to improve the quality of patient care, address health care-associated infections, and reduce health disparity-related gaps in care. Stages of the HIE Incentives Program contain overarching goals to save time, money, and lives, and in 2010, the Patient Protection and Affordable Care Act provided additional access and use of health information as a framework for information exchange that remains compliant with existing legal mandates and requirements. So how else is there buy-in to this system? Monetary incentives are used to encourage health organizations to meet meaningful use criteria by reporting core objectives. Incentives are also based on deadlines and criteria. For example, reporting EHR from January through December 2018 and submitting 2017 meaningful data use attestations by February of this year. Nationally, individual states are encouraged and enticed to participate in the exchange network through federal payment incentives, with just over $500 million of federal funding having been provided to states by Congress as a part of the state HIE Cooperative Agreement Program. The Office of the National Coordinator for Health Information Technology, or the ONC, has established goals and developed HIE communication policies that protect patients' related information while providing patient-centered care. As a part of this incentive program, the ONC also provides grant-funded collaboration and challenges such as the North Carolina Health Information Exchange to help establish successful processes for the exchange of health information. Interestingly, the Advisory Committee, which is the committee that makes suggestions to the ONC, does not require the involvement of a nurse. In fact, the 2018 committee is headed by an MD, with several physicians as medical provider representation, but not one nurse. A review of the 2018 committee positions revealed that there is one vacant slot, which is the Office of the Chief Privacy Officer, that could be potentially filled by an advanced practice or informatics nurse specialist. Two of the largest recognized barriers to interoperability are the variability between systems and healthcare delivery models. As a result, there is an absence in the standardization in which information is exchanged. On a positive note, the establishment of a common healthcare vocabulary, standards of structure, security of transportation of information via encryption, and consistent program interface applications can streamline the health information exchange process and serve as a means to promote interoperability. Chapter 90 from North Carolina's General Statutes dictates statewide laws relevant to the exchange of health information and includes the North Carolina Health Information Exchange Act. This act aims to improve the quality of healthcare delivery in our state via improvements in HIE while maintaining compliance with HIPAA guidelines. Under Chapter 90, Article 29A details the manner in which information exchange must happen between those participating in the HIE network to maintain confidentiality, security, and privacy, including communications between insurers, providers, and for grant funding purposes. 29A states that HIE network information may only be exchanged for the purposes of meaningful use as defined by CMS, and mandates that there must be an opportunity for all people to request to opt out of non-mandated health information exchange. Article 29B contains the Statewide Health Information Act that specifies the legislative access to HIE retrieved data collected across the state. Article 29B recognizes that all information submitted and stored through the network is the property of the state of North Carolina, and that any PHI data cannot be used for any other purpose other than the purpose for which it was originally intended. In addition, this article also states that any data or product that results from the use of the state-owned HIE also becomes property of the state, and that the data cannot be used for commercial purposes. While this mandate aims to protect the data collected in the network, it could pose to be a potential barrier that may place limitations on the creation of innovative informatics solutions that could improve HIE interoperability in our state. And it could result in promoting strategies aimed at creating revenue, such as information blocking by providers and vendors for short-term gains. By keeping the barriers of both federal and state laws in mind, two suggestions that may help facilitate interoperability of HIE in North Carolina were developed. These two suggestions that have potential include an increase in funding as a financial driver for the creation of new and innovative informatics program improvements, and a national and statewide incentive that promotes nursing informatics to further involve nurses at the state level in HIE interoperability development. The creation of new informatics systems for commercial purposes is a competitive business. Because of this competition, IT companies are continually striving to make data collection and interoperability better, easier, and more concise. The limitations of HIE network data use in North Carolina that are cited in Article 29B removes the financial competition that is present in mainstream IT development, thus also limiting the competitive edge for the creation of optimal statewide HIE interoperability. This is particularly true with the pre-existing restrictions on the use of health data and the current fee-for-service system. Increasing incentives while eliminating fee-for-services has the potential to reduce information blocking by providers and vendors for financial gain, which has been shown to be more prevalent when incentives that advance HIE interoperability are weak. Increasing fundings to efforts that aim to improve interoperability utilizing network data in North Carolina could potentially motivate entities. This could mirror the manner in which states are provided financial incentives to participate in the network while remaining ethically true to protected health information. Since the federal grants provided by the ONC do not exceed $2 million per grant, the combination of additional incentives may further evoke competition within the IT industry toward using innovation to optimize HIE interoperability from a business perspective. The second recommendation that could improve HIE interoperability focuses on funding for nurses to participate in collaborations that develop complex and ethically sound solutions. One successful example of nurse specialist collaborations occurred as a pilot study between leaders at Kaiser Permanente and the U.S. Department of Veterans Affairs. This resulted in the development of an evidence-based information model designed to improve interoperability of HIE through the capture, use, and sharing of nurse-sensitive data to improve patient outcomes related to acquired pressure ulcers. Supportive collaborations could potentially be performed through the promotion of nursing informatics degrees, along with incentives for these positions on IT teams such as that of the ONC. In fact, because nurses have served as strong patient advocates and have extensive knowledge about patients' rights and health privacy, it would be ideal that informatics trained nurses serve in positions on health information technology consulting or advisory committees. One example was previously mentioned earlier in this presentation, the current vacant position of the Office of the Chief Privacy Officer. While this idea may challenge the physician-led leadership model in this country, advanced practice nurse specialists have historically been very successful, serving on multidisciplinary teams, in addition to having earned their notoriety as substantial and strong healthcare leaders. Ultimately, by promoting informatics education and specialization in the field of nursing, and supporting the participation of specialized nurses on HIE interoperability committees, richer discussions about how to best protect and share PHI and other data could improve the promotion of patient care quality, safety, and value while adhering to both federal and state laws and protecting patients' rights. This concludes my presentation. Thank you so much for your attention.